everyone, welcome to Thyroid. This is Pack 365, myself Srija. So today in this session you're going to learn about the ICD-10 coding guidelines for the diseases of genitourinary system. So diseases of genitourinary system falls under chapter 14 of ICD-10 coding. So the alphabetical series ranges from N00 to N99. So what are the guidelines for genitourinary system? So the first guideline is about chronic kidney disease. So what are the stages of chronic kidney disease? So what do you mean first by CKD? So CKD means the kidneys are damaged and it cannot filter blood properly for a long period of time. So the severity is divided into stages 1 to 5. So the higher the stage, the worse the kidney function. So in this, what is the stage 1? N18.1. So in the stage 1, the kidney damage with normal function. So in the stage 2, you will code N18.2. In this, there will be a mild loss of kidney function. And in stage 3, you will code N18.30 to N18.32, in which there is a moderate loss of kidney function. And in stage 4, you have to code N18.4, which means there will be a severe loss of kidney function in the stage 4. And stage 5 is also called as end-stage renal disease. So you will code N18.6. So this is an end-stage renal disease. That means almost complete failure of the kidney. So when the provider specifically states ESRD, end-stage renal disease, you have to use code N18.6. So if both the CKD stage and ESRD are mentioned, you should only code N18.6 because end-stage renal disease already means the worst stage. So this is the most important guideline. So the second guideline is the chronic kidney disease and kidney transplant status. So whenever a patient who has received a kidney transplant may still have CKD because the new kidney may not work perfectly, right? So CKD after transplant, it does not mean there is a complication unless the provider states there is a problem with the transplant itself. So how to code CKD in this transplant patients? So you have to use N18 code for the current stage of CKD and you have to use Z94.0 code to indicate the kidney transplant status. For example, if a patient with a kidney transplant and stage 3 CKD is diagnosed, so which codes you have to assign? You have to assign N18 code for the current stage of CKD as well as Z94.0 code for kidney transplant status. So this is how you code when there is a chronic kidney disease showing kidney transplant status. So if there is a transplant complication, so how do you code? So sometimes a patient with a kidney transplant, they may develop problems such as transplant failure, transplant rejection, and other medical complications related to the transplant. So if the provider clearly states that there is a complication, then we must code the complication first. According to section IC19G guidelines in the ICD-10 So if documentation is unclear, the coder should ask the provider for clarification. So this is important because we must know whether CKD is due to a transplant problem or it is unrelated to the transplant problem. Okay. So the third guideline is chronic kidney disease with other conditions. So many patients with CKD, they also have other serious medical problems. So the most common conditions that together with CKD are diabetes mellitus and hypertension. So these diseases, they are often the cause of kidney damage. So correct coding requires deciding which condition should be coded first. So what are the coding sequence rules? The order of coding CKD and the related condition like diabetes or hypertension depends upon the ICD-10 conventions. So when we look into an example, if the CKD is due to hypertension, so you have to code hypertensive CKD first, then code the stage of CKD, whether it is the first stage, second stage or third stage. If CKD is due to diabetes, code diabetes with kidney complications in the range E11.22 first, then you have to code the stage of CKD secondary. Okay, so this is how you have to assign the codes whenever CKD is associated with the other serious conditions. So this is about the guidelines for genitourinary system diseases. So next coming to ICD-10 coding guidelines for pregnancy, childbirth and puerperium. So pregnancy, childbirth and the puerperium codes, they fall under chapter 15. So what are the series? O002, O9A. So general rules for obstetric coding. So what is the first code line? Codes from chapter 15 and sequencing priority. So when a patient is pregnant and comes for medical care, you must use codes from chapter 15, that is O002, O9A code series, to show that condition is related to pregnancy. So chapter 15 codes, they always have priority, meaning they must be coded first before any other chapter codes. So unless the pregnancy is not related to the reason for the visit. So why chapter 15 has priority? Because pregnancy changes how the body reacts to diseases and treatments. And the first code should show that patient is pregnant. So how do you code when pregnancy is incidental? It is not affecting the reason for visit. So sometimes a woman is pregnant, but she comes for something unrelated to pregnancy. Like example, a pregnant woman comes to hospital for a sprained ankle. The pregnancy has nothing to do with the reason for treatment. So in this situation, you have to, instead of chapter 15 code, you have to assign Z33.1 code, which indicates pregnancy state and which is incidental. This means the person is pregnant, but the pregnancy is not affecting the current medical issue. So what is the important note? The doctor must clearly document that the pregnancy is not affecting the condition. So the coder cannot assume this unless and until the doctor mentions it in the document. Okay, remember this one. So the second guideline is chapter 15 codes used only on the maternal record. So codes from chapter 15, the O codes, they must be used only for the mother's medical record, never for the newborn's record. Reason? Because the newborn has already separate codes in the chapter 16, especially for the newborn and infant conditions. For example, if a pregnant woman comes to hospital for high blood pressure due to pregnancy, so you have to assign the code O13.9, which is a gestational hypertension first. And the other example, like if a pregnant woman treated for a cold or flu and a doctor states pregnancy is not affecting the treatment, then you have to assign the code Z33.1 for pregnant state incidental, and it is followed by a cold or flu code. So this is how you have to prioritize the chapter 15 codes. So what is the final character for the trimester? So this is the third guideline, final character for trimester. So many codes in chapter 15, they include a final character. Final character is nothing but a number at the end of the code. So that tells us which trimester the patient is in. So why is trimester important in coding? Because treatment and risk, they are very different depending upon the stage of the pregnancy. So how trimesters are divided? So first trimester is 0 to 13 weeks plus 6 days. Second trimester is 14 to 27 weeks plus 6 days. And third trimester falls for 28 weeks to delivery. So this is how you have to calculate the trimesters. So what are the key rules? The final character shows which trimester the condition happened. For example, O13.2, it indicates the gestational hypertension and second trimester. Another example is if a code does not include a trimester option, that means the condition always happens in a specific trimester or the trimester is not relevant to the condition. And the third rule is some codes apply only to the certain trimester. For example, if a complication that occurs only in the third trimester will only have the ending for the third trimester. Fourth rule is trimester must be based upon the doctor's documentation. The coder should use provider's notes stating weeks or trimester. Currently visit, not previous records. So even if the condition existed before pregnancy like diabetes, the trimester is based upon the current pregnancy weeks only. So the fifth rule is if delivery occurs during the visit, how do you code it? So if the patient is delivering right now and the code has an option in childbirth, so you have to then choose that code. For example, O32.4XX0. So this indicates the delivery in childbirth. So if there is no childbirth option, what you will code? This is the sixth rule. So you have to use the trimester character that describes the trimester at the admission. Right. So here are some examples. The first scenario, if a pregnant woman is 16 weeks with high blood pressure, So how would you code? You will assign the code O13.2, which indicates gestational hypertension second trimester. So next example is pregnant woman at 32 weeks with anemia. So you have to use anemia in pregnancy code ending in 0.3, which indicates third trimester. And the other example is admitted for delivery and baby delivered during the same visit. Then you have to use code with in childbirth option if available. Okay, so this is how you have to assign the codes for final character for trimester. So next is selection of trimester for inpatient admissions that encompass more than one trimester. So sometimes a pregnant woman is admitted in one trimester, but it stays in the hospital long enough to enter the next trimester. So what is the important rule over here? Assign the trimester based on when the complication first developed, but not the trimester at the discharge. For example, if a patient is admitted at 26 weeks, that is second trimester, for high blood pressure due to pregnancy. So she remains hospitalized until 29 weeks, which is a third trimester. So what you will code? You will code the complication as second trimester because that's when the problem began, right? So you have to use trimester of onset, but not the trimester when the patient leaves the hospital. So this is about the fourth guideline clearly. So the complication existed before the admission. For example, like patient already has gestational diabetes diagnosed earlier. So she gets admitted at 33 weeks, that is at the third trimester for monitoring. So you have to code using third trimester character. Okay. So coming to fifth guideline, unspecified trimester. So some ICD-10 pregnancy codes, they have an option for unspecified trimester. So when you have to use it, only whenever the documentation does not tell the trimester and clarification is not possible. They should be used rarely. So what is the example? The chart says pregnancy with vomiting, but no weeks or trimester mentioned. So provider cannot be contacted, right? So you have to use in such cases about this unspecified trimester code. So you should not, there is no need for you to contact the provider and query him. You just assign the code unspecified trimester code. Okay. So coming to sixth guideline, seventh character for fetus identification. For certain categories, a seventh character must be added to indicate which fetus has the complication in multiple gestations, like twins, triplets, etc. So what is the example coding pattern? 031.21x. So let's the last character is a seventh character representing the fetus number. So if the seventh character is 0, it is not specified or single fetus. If the seventh character is 1, it indicates one fetus. If the seventh character is 2, it indicates second fetus. I mean only two fetuses. So if it indicates 3, it is 3 fetuses. So if it indicates 4, there are 4 fetuses. And 5 to 9, it indicates additional fetus identifiers. So for example, if a pregnant woman with twins has growth problem with fetus 2, so you have to assign code 036.4xx2, in which the seventh character 2 indicates that it has twins, that woman has twins. Okay. So the rule of trimester selection in the long hospital stay is you have to use trimester when complication began, and whenever the complication existed before admission, you have to use the trimester at the time of admission. If it is unspecified trimester, you have to use only if the documentation is unclear and cannot be confirmed. So about seventh character, it identifies which fetus in the multiple pregnancy has complication. Okay. So here is a practice example. If a patient with twins is admitted at 24 weeks, which is at the second trimester, with fetal distress affecting fetus 1. So she stays until 28 weeks at the third trimester. So which trimester is to code? So second trimester because the problem started then. Which fetus? Fetus 1. So the seventh character will be 1. Okay. So this is how you have to remember the seventh character plays a major role during the fetus identification. So next seventh guideline is completed weeks of gestation. So in isolated CM, when documenting pregnancy weeks, only full or completed weeks are counted, not the partial weeks. For example, if the doctor documents 39 weeks plus 6 days, so this does not equal 40 weeks yet. So the correct code is for 39 completed weeks, not the 40. So partial weeks, they do not count. Only full weeks are used in the coding. So next, coming to selection of obstetric principle or first listed diagnosis. So choosing the correct primary diagnosis is very important in obstetrics coding. So what are the guidelines? The first one is routine outpatient prenatal visits. So these visits are normal checkups without complications. So for these visits, you have to use code Z34, which indicates encounter for supervision of the normal pregnancy as a first listed diagnosis. So what is the important role here? Codes from Z34, they should not be used together with chapter 15 codes. Why? Because Z34 means a normal pregnancy and chapter 15 codes refer to the complicated pregnancy. You are getting my point. So what will be the example? Like if a woman has 20 weeks pregnancy, she comes for a normal checkup with no problems. Then which code you will assign? Either from chapter 15 or Z category. You have to assign Z category codes. That is Z34.02, which indicates the normal pregnancy, second trimester, which listed as the first listed diagnosis. Okay. So, knowing whether it is a complicated pregnancy or it is a normal pregnancy is very much important to assign the chapter 15 codes. So, the second guideline is related to the supervision of high-risk pregnancy. So, some pregnancies, they need more care due to higher risks such as diabetes, hypertension, teenage pregnancy, elderly pregnancy, multiple gestation like twins or triplets, past miscarriage history. Like for high risk pregnancies, you have to use codes O09, which indicates supervision of high risk pregnancy. This is used only during the prenatal period before the delivery. For example, if a 40-year-old pregnant woman, she comes for checkup. So you have to assign code O09.513, which indicates the supervision of elderly multigravida third trimester. So here are some quick practice questions. The first one is, if a woman comes at 28 weeks for a routine checkup, there are no problems. So which code you have to assign? You have to assign Z34.03 because it indicates a normal pregnancy and third trimester, right? So the second question is, a 22-week pregnant woman with gestational diabetes is at prenatal visit. So you have to assign code O24.41, which indicates gestational diabetes and second trimester from the chapter 15 code. So provided documents 36 weeks and 4 days gestation. Which week and in which trimester you have to indicate over there? You have to code for 36 weeks because there are only 4 days, right? They have mentioned only 4 days. Until and unless they mention 7 days, it is considered as a week. This is incomplete week count, right? So you have to code only for 36 weeks. So this slide, it explains how to choose the correct diagnosis codes for the patients with high-risk pregnancies, especially during the labor, delivery or prenatal visit. So let's break it down step by step. So complications during labor or delivery, high-risk pregnancy. So if a woman is high risk and she has complications during labor or delivery, you must use chapter 15 codes. So these codes that describe the obstetric complications such as high blood pressure, diabetes in pregnancy, fetal issues and preterm labor. And also breech presentation. So what is the rule over here? You have to assign the specific chapter 15 code that describes the complication that happened during the labor or delivery. So the second line is no complication during labor or delivery. So if the mother is high risk but the delivery happens normally with no complications, so you have to use O80 code which describes encounter for full term uncomplicated delivery. So this code is used only when delivery is normal and there is no complications during labor or delivery and no high risk issue affected the labor or delivery outcome. So the rule over here is OIT is used only for a completely normal delivery with no complications. Okay. So the third guideline is routine prenatal outpatient visits for high-risk pregnancies. So when a high-risk pregnant woman visits the clinic for routine checkups, not labor, only for routine checkups. So you have to use category O09 for supervision of high-risk pregnancy. So this is used as the first listed diagnosis, which is a primary diagnosis. So what are the examples of high-risk supervision? History of miscarriage, multiple pregnancy supervision, elderly primigravida, previous C-section pregnancy, hypertension or diabetes needing supervision. So what is the rule? You have to use O09 codes first. Then you have to add additional chapter 15 codes if needed. Okay. So next guideline is episodes when no delivery occurs. So this refers to the cases like pregnant woman comes to ER with pain but is sent to home. So hospitalized for monitoring but baby is not delivered. So they are treated for a complication during pregnancy but discharge occurs before the labor. So in this case, what is the primary diagnosis? You have to use the main pregnancy complication that is caused in the visit. So if multiple complications exist, you may choose any complication as a principal diagnosis as long as all were monitored or treated. So what is the example? Patient comes with high BP, that is gestational hypertension, and as well as mild bleeding. Both are treated. Either code can be sequenced first. So next guideline is when the delivery occurs. How would you assign the code? So if a pregnant woman is admitted and delivers during the same admission, so what will be the primary diagnosis? So the condition that caused the patient to be admitted must be coded first. For examples like if admitted for induction due to gestational diabetes, so here gestational diabetes is the principal diagnosis. And the second example is if admitted for pre-eclampsia but delivers later. So pre-eclampsia is the principal code. So if it is admitted for labor pain which is normal and delivers, you have to assign the code for labor or delivery category accordingly. So next is if multiple conditions cause the admission, how would you code? So sometimes a pregnant woman is admitted with more than one problem before the delivery. For example, like high blood pressure, prolonged labor and fetal distress. So all may be present. So what is the rule here for coding? You have to choose the condition that is most related to the delivery as the principal diagnosis. So you have to pick the problem that most directly affected the delivery processes. So complications of the delivery, you have to add as an additional code. If anything goes wrong during the delivery, you must also code it. For examples like delivery complications, postpartum hemorrhage, prolonged labor, perineal tear, and shoulder dystocia. So what is the rule over here? And any delivery complication gets coded as an additional diagnosis, but not the principal diagnosis. So if a C-section is done. So if a C-section may be planned or emergency, the reason for the C-section decides the principal diagnosis. So if the patient was admitted because of a condition requiring C-section, examples like placenta previa, cephalopelvic disproportion, breech presentation, and fetal distress. So the condition becomes a principal diagnosis. In the other case, if the C-section happened for a new reason discovered after the admission. So the example is patient admitted for gestational diabetes. During labor, fetal distress occurs. So here the C-section is done. So gestational diabetes, it stays the principal one. What is the key point? If the admission reason and the C-section reason are different, you should always choose the admission reason as the principal. And the fourth guideline is if the admission reason was not related to the C-section, what you will code? So sometimes the woman is admitted for an unrelated issue like severe vomiting, dehydration, infection or accident injury. But later she ends up delivering by C-section. So what is the rule here for the coding? You have to use the condition that caused the admission as the principal diagnosis. So even if the delivery later required a C-section. So this is how you code if the admission reason was not related to C-section. And the fifth guideline is outcome of delivery. So category Z37. So this is a very important rule. A Z37 code, it must be included on every maternal record where a delivery occurred. For example, like Z37.0, which describes for single live born, Z37.1 for single stillborn, Z37.2 twins both live born, and Z37.4 twins some live born and some stillborn. So what is the important rule? You should not use Z37 code on follow-up visits, postpartum records after discharge and newborn charts. So this Z37 is exclusively used only on the mother's delivery record. Okay. So this is the guidelines related to pregnancy coding. So this is for today's session. I hope this session has helped you. So in the next session, you will be learning the continuation of this chapter 15 ICD-10 CM coding guidelines. Thank you.